This conference will now be recorded.
It is mentioned in the literature under different names like cesarean section scar, uterine scar defect, niche, ethmocoel, uterine diverticulum. And as we can see here in the photo here in the diagram, that this is where the niche is formed. On the ultrasound, this is again where it is located, and on the specimen, uterine specimen, you can see clearly this very thin uterine wall segment and the presence of the niche. So the cesarean section scar is defined as the presence of a hypoechoic area within the myometrium of the lower uterine segment, reflecting a discontinuation of the myometrium at the site of the previous cesarean section. And it can have different shapes, as we can see here from the diagram. It can be triangular, it can be
دكتور محمد الصور مدى تظهر بسلايدات بدون زحمة.
You cannot see me clearly. طيب واضح كده؟ لو في حاجة يا جماعة قولوا، لو مش واضح قولوا إن هو مش واضح.
طب يا جماعة لو حد في حد تاني مش شايف الصور؟ في حد مش شايف السلايد؟
واضح واضح.
اي صور ما واضحة عندنا.
واضح.
عندنا طالع الصور واضحة.
طب
احنا ما طالع عندنا واضحة.
غالبا هي مشكلة انترنت. بإذن الله عموما يعني إن شاء الله هيتم رفع المحاضرة بإذن الله.
مشكلة عندي.
هي غالبا هتبقى مشكلة انترنت. بإذن الله نكمل المحاضرة، ولو في مشكلة إن شاء الله هنرفع المحاضرة تاني على النت وهي مسجلة.
شكرا.
نكمل.
تمام.
Cesarean section niche can have different shapes. As we can see here, it can be triangular in shape, can be semi-circular, it can be rectangular, can be like a circle, can be doublet shaped, and can be inclusion cyst. So these shapes can appear on the ultrasound picture, any of these different shapes. But why this niche is formed? There are different possible factors that could play a role in the niche development, including the very low incision through the cervical tissue. If we open the cesarean section very low, it can result in such formation of the niche. Inadequate suturing technique during the closure of the uterine incision. And in this respect, the single layer closure has been implicated as a cause or a reason why the niche is formed. Of course, this needs to be studied on a wide scale, but for now, the possibility of formation of niche is increased with a single layer closure of the uterus. Non-closure of the peritoneum has been postulated. Other factors like the patient-related factors that impair the wound healing or increase inflammation or adhesion formation. So till now, there's no certainty why the cesarean section niche is formed, but there are different possibilities. Approximately 30% of women with a niche report spotting at 6 or 12 months after their cesarean section. So it's not only can cause obstetrical problem in the form of cesarean section scar, but gynecological problems as well has been reported, like the postmenstrual spotting, dysmenorrhea, chronic pelvic pain, dyspareunia as well, and in addition to possible subfertility. The mechanism probably by if you have the blood for a long time inside this niche, even if it is a small amount, this can cause inflammatory reactions and inflammatory mediators that can affect, for example, the fertility, the implantation of the embryo. among other factors. Okay, so now we know about the cesarean section niche and how it is formed, and now we come to the cesarean section scar pregnancy, our main topic. It is defined as a partial or full implantation of the gestational sac into the myometrial defect occurring at the site of the previous uterine incision. Simply implantation at the site of a previous cesarean section scar. And this has been reported since a long time. The first case report was reported in 1978 by Larson and Solomon, and it has an incidence of roughly 1 in 2,000 deliveries or pregnancies. So if you are in an obstetric unit that sees or delivers probably 10,000 deliveries per year, so you are expected to see 5 or 6 cases of cesarean section scar. So it's getting more common, and the diagnostic and the diagnosis is improved all the time. So this is likely to increase due to increasing number of cesarean sections. This will increase the cesarean section scar pregnancy problems, IVF and embryo transfer, as well as increasing the awareness and better ultrasound diagnosis. So all these factors will result in an increasing incidence of cesarean section scar pregnancy. But why it happens? Why the pregnancy implants in a cesarean section scar? Again, these are theories, and nothing is confirmed as yet. One of the theories is endometrial disruption or scarring. This favors abnormal pregnancy implantation at the site of the scar. The blastocyst implants through a microscopic tract within the cesarean section scar. So there's an implantation in the endometrium, and there's a tract between the scar and this endometrium, and the blastocyst goes through this and implants in the cesarean section. Another theory, whether there's an effect from the previous surgery on the endometrium and make its implantation is different. Again, we are not 100% sure. There is no clear correlation between the number of previous cesarean sections and the risk of cesarean section scar. So this means if the previous cesareans, the more cesarean section, the more the cesarean section scar. This is not proven as yet. And there's a higher risk of scar pregnancy with higher uterine incisions. We said before that the possibility of formation of the niche is increased if the incision is lower, but the possibility of scar pregnancy to occur is higher if the uterine incision was high. So why it is a serious problem? Can we continue pregnancy as if nothing happened, as if it is normal? The answer is no, because there was a case series of 35 women elected to continue pregnancy with cesarean section scar. What happened to them? There had been 27 live births out of the 35. 22 of them, which means more than 60%, had emergency hysterectomy between 15 and 38 weeks due to hemorrhage or morbidly adherent placenta. So the consequences of continuing pregnancy of a cesarean section scar are very bad. A lot of hysterectomies, 60%, 6 out of 10, and a significant hemorrhage can occur as well. There are numerous case series of intra-abdominal rupture and severe vaginal hemorrhage at the point of diagnosis or following intervention. So the rupture, not only it can cause bleeding from the adhesion into the uterine wall, but also can rupture inside the abdomen and cause intra-abdominal bleeding. Again, it's another problem. And as well, it has been linked to maternal deaths if not diagnosed and appropriately managed. So ranging from massive blood transfusion to hysterectomy to intra-abdominal bleeding and even to maternal death. So the cesarean section scar pregnancy is a serious clinical diagnosis. How does it present to us, the cesarean section scar pregnancy? First, the most common, it is diagnosed incidentally. So a woman coming in her first trimester to do an ultrasound to follow up her pregnancy, and you'd find the sac is implanted lower down in the uterine cavity. So you start to think whether it is a cesarean section scar or not. So incidental finding is the most common, followed by slight BV loss. Sometimes the patient can have some abdominal discomfort, and rarely there's acute abdominal pain or profuse vaginal bleeding, or you can diagnose it. And we have seen some of these presentations. You go and do evacuation of the uterus for presumably missed miscarriage, and you find massive vaginal bleeding during the operation. And it may have been a cesarean section scar pregnancy, that it was not diagnosed, and during the evacuation, the patient bled a lot. So again, this is one of the presentation during or after surgical evacuation of missed miscarriage. Is it clear, يا جماعة? Dr. Muhammad, everyone is listening? Because I'm not
Yes, Dr.
taking...
Waleed. Yes, Dr. Waleed.
كله
Okay, thank
تمام.
you. كله تمام. Because it's difficult with no face-to-face interaction to know what's going on here. Imaging, how would you diagnose this? So you diagnose it by ultrasound. Ultrasound is the mainstay of the diagnosis. So if you have a good machine and a good sonographer and you have enough experience, you can easily diagnose the cesarean section scar pregnancy. You don't need extra modalities of diagnosis. So transvaginal scanning has a reported sensitivity of 84.6% and remains the imaging modality of choice for diagnosis of scar pregnancy. Combined transabdominal and transvaginal scanning has a high diagnostic accuracy. The importance of the transabdominal is that it will give you a panoramic view of the pelvis abdominally, and of course, the transvaginal scanning will locate the exact location of the pregnancy quite clearly. 3D TVS has also been used, and MRI is occasionally needed. So mainly the MRI would be used if you have like huge uterine fibroid and you cannot locate the exact location of the sac. So you can use MRI, will give you a better idea. But usually transvaginal scanning is enough. So what are the diagnostic criteria by ultrasound? Well, as you can see here from the slide, there are a lot of diagnostic criteria. We'll put it on this one, would be a little bit clearer. Well, first you will have an empty uterine cavity here, as you can see. There's nothing in the uterine cavity, as well as empty and closed cervical canal. Okay, so both the uterine cavity and the cervical canal are empty. Then you would have a gestational sac or a sac embedded at the cesarean section niche here. So this is a place of the cesarean section niche, as we said before, at the reflection of the bladder just above the cervix. So uterine cavity empty, cervical canal empty, and a sac implanted in the place on the site of the cesarean section. This is another diagnostic criteria. Then you would find absent or very thin myometrial layer between this gestational sac and the bladder. Okay. The last one in this slide, you may or may not find a yolk sac, an embryo inside this sac. So empty uterine cavity, empty cervical canal, gestational sac at the site of the cesarean section with a thin or absent material overlying it, together with yolk sac will be present. Okay. The other thing is that you will find functional trophoblastic or placental circulation on color flow. So this sac that is implanted at the site of the cesarean section will have color flow around it. So this can differentiate it between the viable or cesarean section scar pregnancy and an missed miscarriage or inevitable sac that's coming from the pancreatic downwards. So the presence of functional trophoblast or placental circulation would increase the possibility of the diagnosis of cesarean section scar pregnancy. In addition to the sliding sign, this is a very important sign. When you do transvaginal scanning and apply pressure on the cervix by the vaginal probe, and the gestational sac slides against the enterocervical canal, okay, this means that it is not attached to the cesarean section niche. If it slides, this means it is an missed miscarriage or abnormally located pregnancy. But if it is at the same place, does not move, this means it is a cesarean section scar pregnancy. So if the sac is implanted within the cesarean section scar or in the cervical canal, because the sliding sign is negative as well in the cervical pregnancy. If this gestational sac does not slide with pushing of the vaginal probe, this means it is fixed to a place which is either the cervical canal or the cesarean scar. So this is a negative sliding sign, and it is keeping with cesarean section scar. If the sac moves inside, in and out, this means that it is a missed miscarriage or blighted ovum that has been moved from the uterine fundus down to this place. I hope this is clear. The MRI, it is useful. The MRI is useful when the ultrasound scanning is difficult, like for example, as I said before, in large fibroids, and in the later stages of gestation, like 12 weeks, 13 weeks, 14 weeks, can be the scan, ultrasound scan may not be that accurate, and you may use the MRI as well. But in early pregnancy without any uterine anomalies, ultrasound should be enough. And if you were asked, would you use the MRI with contrast or without contrast? So you choose MRI with contrast. So it will give you a better delineation of the sac. So now we talked about the diagnosis and ultrasound and how we can diagnose it. So what about the classification? We have two types of cesarean section scar pregnancy. The first one is type 1 or endogenous, and the other one is type 2 or exogenous. Simply, if the sac is growing inside the endometrial cavity, it is an endogenous or endogenic cesarean section scar or type 1. If the sac is growing towards the bladder and inside the abdominal cavity, it is exogenous or exogenic or type 2 cesarean section scar. As you can see here, this is type 1, when the sac is going from the cesarean section scar towards the uterine cavity, and the other one where it is pointing out to the bladder and then the abdominal cavity. This is a sign is called crossover sign. In simple words, you can take the longitudinal line taking the uterine cavity, and if the sac, as you can see here, is above this line towards the bladder, it is crossover sign 1, which means it is equal to the exogenic type. If the sac is below this line, it is crossover sign 2, which means it is the endogenic type. So it's another one that you can help us. But as you can see, this is only with small sacs. We are talking about 6 weeks, 7 weeks, 8 weeks as the most. But if you are having 12 weeks pregnancy or 10 weeks or later gestational age, you cannot apply these signs quite clearly. Again, there's another classification or grading, grade 1, 2, 3, 4, and the same idea. Grade 1 represents the depth of scar pregnancy embedded in less than 1/2 thickness of the lower anterior corpus. Here, less than half. Here is more than 1/2 of the thickness of the myometrium. Okay. And grade 3, bulging and going through the uterine serosa. Okay. And the last one, when the same as number 3, but the sac is not as clear as number 3 and just changing into an amorphous tumor rich in vascularity. Again, this is another classification. So if we can see here, the simple one, again, is type 1 endogenic, type 2 exogenic, inside the cavity or towards the bladder. You have the crossover sign, again, longitudinal line in the uterine cavity, above it crossover sign 1, below it crossover sign 2. And there's grades according to how much through the myometrial thickness the sac is implanted, less than 1/2, more than 1/2, bulging through the uterine serosa and formation of amorphous mass. These are laparoscopic and surgical pictures of the cesarean section scar pregnancy. This one is here. You can see the bulge here and the anterior uterine wall. Okay, and here in this surgical or laparotomy, you can see here clearly the placenta or vascularity at the lower uterine segment. Again, this is cesarean section scar pregnancy. So what are the differential diagnosis, which is very important? These are the diagnostic challenges of cesarean section scar pregnancy. The first one, we have the inevitable miscarriage with low-lying gestational sac and cervical pregnancy, which represent around 40% of the diagnoses. Okay, so if you have an inevitable miscarriage and the sac is coming from the fundus towards going outwards, and on its way, it is in the region of the cesarean section, previous cesarean section scar, you can be confused whether it is inevitable miscarriage or scar pregnancy. What is the importance of this? If you don't diagnose it properly, you probably will go and do evacuation of the uterus, and if it is cesarean section scar, you can be faced with horrible bleeding. For you, it will be unexplained why you are having such bleeding, but you have been misdiagnosing this clinical entity from cesarean section scar into inevitable miscarriage. The challenge is that in diagnosis, well, you have to think about the cesarean section scar pregnancy. especially nowadays. Now with the cesarean section rate is very high. So the last census in Egypt is more than 50%, and I'm sure in some places it is more than that. So you have a lot of things you can expect to have cesarean section scar pregnancy a lot. So you would not diagnose it if you don't think about it. The same applies for ectopic pregnancy. You will not diagnose ectopic pregnancy unless you think about ectopic pregnancy. So if you have a low index of suspicion, you might not diagnose cesarean section scar pregnancy. Unavailability of high resolution ultrasound. It's not just seeing the fetal heart and the crown rump length and that's it. With the older machines, if you have a good new machine, you would be able to diagnose this easily. If you don't have it, so the diagnosis can be a little bit difficult. And lacking the skill and experience in diagnosis. Again, this is very important. So this is related to the facilities and the skills of the operator. What are the difficulties that can face the doctor in diagnosis? But also in the clinical situation as well. If it is advanced pregnancy, more than 12 weeks, and it is an endogenous type, so the scar pregnancy formed and grow into the uterine cavity, it may be difficult to diagnose as well. Impending miscarriage, as I said, it is inevitable miscarriage going through the fundus towards the cervix can be difficult as well. Cervical pregnancy, a little bit easier to diagnose, and missed miscarriage. So the first one is the impending miscarriage. The early phase of miscarriage can mimic cesarean section scar pregnancy. As I said, the sac is being expelled from the fundus to the outside. The impending miscarriage, the gestational sac is often irregular and located within the uterine cavity with absent or minimal color flow. These are very important. The sac will not be regular sac as in cesarean section scar. The impending miscarriage, it will be irregular. It will be located within the uterine cavity, so it is not inside the cesarean section scar. And the blood flow will be absent or minimal blood flow, because it is already detached from the endometrial cavity and going outside. Okay, and again, the positive sliding sign. So if you push against the cervix by the transvaginal probe, this sac will move up and down because it is not attached to the cesarean section scar. So it is a positive sliding sign. So this is the first one. The second one, the cervical pregnancy, it will be present in or close to the cervical canal with ballooning of the cervix. So the most important thing which differentiates the cervical pregnancy from cesarean section scar is the ballooning of the cervix. The cervix will be enlarged, ballooned, not like a tube. Okay, this is absent with cesarean section scar. The same will be in both with good color blood flow. Again, the same will be in both with negative sliding sign. Negative sliding sign will be present with the cervical pregnancy and with the section scar. So the differentiation here is the ballooning of the cervix. Missed miscarriage, if endogenous scar pregnancy becomes missed, it can be difficult to diagnose, especially later in the first trimester. So if it is a missed miscarriage and located in the lower segment, sometimes it can be difficult, but again can be diagnosed. So we come to the next point. Does early diagnosis make a difference? So suppose you diagnosed the scar pregnancy at 6 weeks or 16 weeks. And this is a study done actually by Davesky in 2018. He compared the diagnosis of scar pregnancy at 6 weeks and at 16 weeks. So the hospitalization time was only 3 days at 6 weeks 10 days at 16 weeks. Transfusion, 1,200 mils of blood transfused on average when the diagnosis was made at 16 weeks. A transfusion of fresh frozen plasma, the same 600 mils compared to nil. Antibiotic therapy, 10 days compared to 3 days. Fertility loss, yes, because at 16 weeks you might go for hysterectomy. At 6 weeks, it's very unlikely to do that. Direct risk of death, yes, again, if you go for hysterectomy and there's massive blood loss, there's a danger to the mother's life. At 6 weeks, the difference is there's no or minimal, I would say, such risk. So it is very important if you do proper antenatal care to try and diagnose this problem as early as you can. Okay, so what is the management of cesarean section scar? We talked about the diagnosis, differential diagnosis, and how it is formed. Unfortunately, there is no consensus on the preferred mode of treatment. There's a lot of treatment modalities, as we will see later on, and there's no consensus about which one is the best. All treatment options carry risk of hemorrhage and subsequent hysterectomy. Treatment should be individualized based on full pre-treatment evaluation, and we'll come to this later. In principle, pregnancy should be ended as soon as possible after confirming the diagnosis, with the aim of removing the gestational sac and scar pregnancy mass to retain future fertility. Because this, I personally know some people who diagnosed sectional scar pregnancy early, and they elected to continue the pregnancy. They did not make a big issue about them. We talked earlier about that sectional scar will end up most likely by placenta previa accreta or procreta, with the possibility of hysterectomy and loss of fertility. So if you diagnose sectional scar pregnancy, you have to end the pregnancy. You have to end the pregnancy. Don't say that there's a fetal heart is positive, and this can be an individual that can come out and at the end of the day, you can end up by losing the mother herself due to bleeding, and if she survived, she will most likely lose her fertility as well. So it's very important to diagnose it early, to treat it early. So the management options, as you can see here, there are a lot of management options here. We have the expectant management, the medical management, the local injection and embolization, the surgical management, and the combined or sequential management. We'll talk about each one of these as we go on. So what are the factors that influence your choice for the management? We have the patient factors, cesarean section scar pregnancy factors, facilities as well that you have in your department. So if the patient is coming, the symptoms like bleeding, if the patient is having bleeding, whether this vaginal bleeding or intra-abdominal bleeding, if the patient is coming with pain, severe pain, you have to interfere, and your interference will be most likely by surgical approach. Okay, you will not wait and for expect management or medical management in a patient who is bleeding, for example. Fertility wishes. So a woman who is, say, has previous one section, and she did not complete her family, your treatment options or choices will be different compared to a para 7 who had three previous sections and have section scar. Okay, you may elect to do hysterectomy from the start in a previous 7 with section scar, but you will not do that for para 1 with previous section. The acceptability of prolonged follow-up. So a patient when you talk about the medical management, we are talking about 2 to 3 months of follow-up. 2 to 3 months. It takes long time for the beta HCG to drop, for the gestational sac to be expelled either naturally or by surgical evacuation. So if the patient is not willing to have a long follow-up, you will not choose a medical management for her. You can go for the surgical management. Associated lesions, like for example, uterine fibroid and section scar, can change your management. Surgical risk factors. If the patient is not fit for surgery for any reason, you can choose a medical management for her. Response to initial treatment. So if you are giving methotrexate, for example, and she is not responding, you might switch into the surgical approach. And if sometimes you give a single shot of methotrexate and the baby dies straight away, and things will go nice and easy for the patient. So the response to initial treatment will differ and will affect your choice. This is regarding the patient factors. Regarding the SAC factors itself, the gestational age, 6 weeks will be different to 16 weeks, as we said earlier, and the new management approach. HCG levels, low levels, will be different completely to very high levels. Low levels if the SAC is very early, 5 to 6 weeks, and you're not sure about the viability, and beta HCG is low, when you start it will be more successful compared to beta HCG level of 90,000 at 8 weeks, for example. Okay, so the beta HCG level can influence your management choice. The size of the scar pregnancy mass as well, a small one, most likely will be successfully treated by medical treatment. Large ones is not. Type of the cesarean section scar. When it is endogenous, you feel a little bit safe when you give the medical management. But if it is exogenous, as we have seen in some patient, bulging through the serosa and into the bladder by the ultrasound scan, you would be anxious that anytime this exogenic type of scar pregnancy can rupture at any time and cause significant bleeding. So this is another factor. Myometer thickness, if it is thicker, gives you time to do medical management. Viability of the fetus again. If it is missed miscarriage in a scar pregnancy, you can have expectant management. Wait until spontaneous expulsion. But if the fetus is viable, you have to do something. The facilities as well play a role. If you have a good intervention radiology department in your hospital, which can help you in the treatment, this would be very good. Surgical experience, if you have a surgical experience with removal of the scar pregnancy, again, this is helpful. And monitoring facility for ultrasound scanning and beta HCG follow-up, again, this makes some difference. So you have a lot of factors in the patient, in the scar itself, and in your department and yourself as well with your experience, which can affect the management choice. So we'll start by the expectant management. So when can you do expectant management for cesarean section scar pregnancy? Only in asymptomatic women with a non-viable scar pregnancy and declining beta HCG. So you do the scan, you find like missed miscarriage inside the scar or blighted ovum inside the scar, and the beta HCG you follow up by the beta HCG and it is dropping. So you don't need to give methotrexate, you don't need to do surgical intervention for this patient. You just wait until expectant the uterus contracts and expels what is inside. So this is only viable in viable. This is a viable option in a non-viable cesarean scar beta ECG. Rarely in women with cesarean section scar pregnancy growing towards the uterine cavity who decline termination of pregnancy because of this, reduce the chance of future conception. So this is a very rare example, So this is a 42 years old who has one child and has been trying for a long time for pregnancy, and she is pregnant. She's pregnant, and the pregnancy in the scar. So will you terminate the pregnancy, or will you wait and continue the pregnancy and then do cesarean hysterectomy at the end? This is a difficult and rare scenario, but this should be put in mind. After full counseling with the patient about all the risks, all the complications that can happen if she continued the pregnancy. Okay. The medical management, methotrexate is the drug of choice in the medical management in hemodynamically stable cases with unruptured cesarean scar pregnancy. It is given at the same regimen as that for tubal ectopic pregnancy, which is 50 milligrams per square meter intramuscularly. Before giving the methotrexate, we should follow up by the usual biochemistry lab. The CBC, the liver function, and the renal function should be done before that. And adequate counseling regarding the likelihood of prolonged follow-up. Again, I would stress about this prolonged follow-up. You tell the patient if you are going to medical management, you can take up to 3 months of follow-up visits and lab investigations. So adequate counseling regarding the likelihood of prolonged follow-up, repeated HCG test, need for additional treatment doses because the first dose may not work. You may need to give her another dose, and the possibility of surgical intervention, including hysterectomy as well. The success rate is 41% with a single dose of methotrexate. If you give single dose of methotrexate, it has 41% treatment success. And it is more successful if the beta ECG is less than 5,000 international units and gestational sac less than 8 weeks. As we said earlier, these are some of the factors which can affect your choice in the treatment. If you have a low beta ECG, if you have a low gestational age of the sac, then you can choose the medical management and single dose methotrexate, and it could be successful. Another route for methotrexate can be the local injection, the local embryocytes. Of them, methotrexate is the most commonly used, but others like potassium chloride and etiposide and hyperosmolar glucose has been tried as well. But again, methotrexate is the most commonly used. You start by it's the same as those of you who work for IVF or have experience in IVF. This is the same needle and the same procedure as you do it for embryo reduction. So using a transvaginal probe and needle or on a needle guide, you pierce the gestational sac, you aspirate the fluid, amniotic fluid that is there, and you inject the methotrexate. Different treatment regimens as well has been used, like give the full dose that you give intramuscularly, you give it inside the sac, and others have given only half the dose inside the sac and other half intramuscularly. As I said, there are different treatment options and regimens that you can use. So transabdominal and transvaginal injection approaches are both feasible, but transvaginal is more advantageous. The time required for complete resolution of the ectopic mass correlates with the initial sac size and beta HCG. Again, this is what we said in the previous slide, that the gestational sac size and the beta HCG levels correlates very well to the treatment success and the time needed to finish the treatment protocol. Okay. The local injection and embolization, which is the combined local and systemic methotrexate. So gestational sac aspiration plus methotrexate local injection and systemic methotrexate has better success rate and requires fewer additional intervention. Technique of this is that first full dose of methotrexate is either injected directly into the scar pregnancy or maybe divided equally with half administered into the sac and other half given intravascularly. And further doses can depend on the beta HCG decline. And the treatment success percentage is 75%. Okay. Other treatment modality or other treatment option. You use uterine artery embolization. When you use uterine artery embolization, you deprive the gestational sac from the blood flow, which can enhance the effect of the systemic methotrexate or local methotrexate and effect on the fetus. So you can use both the embolization and methotrexate in the treatment. The median time for beta HCG levels to normalize was 37.7 days, and mean time for resolution of the mass was 33 days. Sorry guys, is it all clear? Are you hearing me well? Okay.
Yeah.
Yes, okay.
Okay. So again, this is a local injection and the embolization. So we'll try, because the many treatment options that you have can be confusing a little bit, but I will try to summarize it so you can grab what we can do in. So now we talked about two things: the expectant management, and we said that it's only in a non-viable pregnancy with declining beta HCG. Okay, and the very rare case of a woman who has no other chance of getting pregnancy, and this is her only hope to have a child. This is an exceptional scenario. The medical management, the mainstay of it is the methotrexate. There's one treatment regimen that is not mentioned here is multiple dose methotrexate. So the medical management is mainly based on methotrexate, whether you give it as a single administration, like we do it in ectopic pregnancy. You give it as multiple dose, like we give it again in some cases of ectopic pregnancy, on day 1, 3, 5, 7, methotrexate and folinic acid, day 2, 4, 6, and 8. So single dose, multiple dose, local injection inside the gestational sac, either the full dose inside the gestational sac, or you divide it half and half, or in addition to other things like uterine artery embolization. So you do uterine artery embolization in addition to methotrexate. Okay, so can have different options as we said here. Now the surgical management. The surgical evacuation, mainly DNC, is suitable for endogenous scar pregnancy with a myometrial thickness of at least 2 millimeters above the sac. So you can do dilatation and curettage or suction. Suction would be better, of course. Suction evacuation of the gestational sac in cesarean section scar pregnancy. Okay. So the risk of bleeding and failure to remove all the pregnancy tissues is there. There's always a risk of bleeding when you deal with a cesarean section scar pregnancy. But you can use it. You can use the surgical management in addition to different treatment modalities like uterine artery embolization plus or minus methotrexate. To do it using the ultrasound guidance, you can use to stop or to minimize the bleeding that can happen after the evacuation. You can use either the intrauterine Foley catheter or short care suture. The intrauterine Foley catheter, after you do the evacuation and you would expect some significant bleeding to occur, you can insert the Foley catheter inside the uterine cavity and fill it by 15 or 20, 15 mils will be 10 to 15 mils of saline, and then pull back on the cervical canal. This can minimize or reduce the bleeding. You can again use a short care suture and to apply very high and the cervix. This again can compress and reduce the bleeding from the site of the implantation. Okay, so surgical evacuation and suction evacuation are one of the options. The surgical management, other options will be the abdominal or laparoscopic resection. The advantages is that it completely removes the products of conception. The possibility of repairing the myometrial defect is there. So after removal of the scar pregnancy, you can repair the scar. Beta-HCG levels quickly return to normal because you completely remove the sac straight away. Early discharge from follow-up is possible, of course. This can finish in a few days. You can diagnose, treat, and discharge the patient straight away. It is preferred in the exogenous cesarean section scar pregnancy with a thin overlying myometrium. Yes, because the possibility of rupture of the exogenous or exogenic scar pregnancy is there when it is bulging through the uterine serosa. So it is a good option to do and to remove this scar pregnancy and repair the myometrial defect. Using the laparoscopy or laparotomy, of course, will depend on the surgical experience of the operator. As a slide shows here, it can be used as primary procedure or after methotrexate treatment. So the combination of treatment is always there. You can start by methotrexate. If it is failed, you can move into the surgical approach. You can hear, as you see from this slide, this is a thinned and ballooned out lower uterine segment due to the presence of cesarean section scar pregnancy. Okay, and the treatment option here was the surgical removal of the scar pregnancy. This is after it was open, and I have a few cases of surgical removal of cesarean sexual scar pregnancy, and you would be surprised by the amount of bleeding that can occur. So it is not that much different from placenta previa, I would say, especially if it is of the exogenous type and the vasculature around the lower uterine segment or lower part of the uterus and the bladder is very high. So you can see the fetus is being removed together with the trophoblastic tissue from the lower uterine segment. Again, this is to those of you who do cesarean section for placenta previa or placenta previa accreta. This is almost the same view here on the black circle. The blood is coming from the thinned out lower uterine segment, and there's sometimes a lot of bleeding from this place. And at the end, you can successfully repair the lower uterine segment. So this is one of the good things about the surgical approach, is that you can repair the lower uterine segment. So we talked about the dilatation and curettage and the section evacuation and laparoscopic or laparotomy and removal of the scar pregnancy. There are other. Can you hear me well, or Adan interfering?
Oh, it's okay.
Okay. Other treatment options, of course, this needs some experience, is hysteroscopic resection. Whether it is primary, so you start by doing the hysteroscopic resection straight away, or sequential after using methotrexate as a first treatment option. Transvaginal resection, closure of the defect by this approach may be easier. What is meant by transvaginal resection is that you were going to open, you pull the cervix and open the vaginal wall and dissect the bladder as if you are doing cystocele, and then you will reach the lower uterine segment and the cesarean section scar. You can remove it and repair it. So this is meant by the transvaginal resection, not transcervical, transvaginal resection. Again, this needs some experience. And hysterectomy, of course, as we said at the end, at the start, if you have a patient who is para 7 or para 8 and has scar pregnancy, you can go straight away for hysterectomy, and they will end this is one of the options. If she agreed, you can go for that.
Sorry again, the transvaginal resection. I cannot understand it.
Okay, transvaginal resection. Imagine you are doing a cystocele repair. What do you do? You pull on the cervix, isn't it? And then you open the vaginal mucosa above and dissect the bladder up. Is that right? Okay. Then, if you do this, and you will find the cesarean section scar pregnancy in this area, above the cervix.
Yeah.
Okay. So after pushing, this is, by the way, the same technique that is used in repairing cesarean section niche. Some people do the same procedure by dissecting the vaginal wall up and getting to the anterior uterine wall from the vagina down, and then close the cesarean section scar defect. If you have a cesarean section pregnancy, you can, after dissecting the vaginal wall, you will find the scar pregnancy in front of you, lower uterine segment. You can remove it and repair the defect. So this can be an option if the woman has first or second degree uterine prolapse, where you can pull the uterus downwards, and if you have enough experience to deal with this from this approach. Okay.
Okay.
This is the hysterectomy specimen, and as section scar pregnancy is quite clear as well. So hysterectomy is one of the treatment modalities and treatment options for this problem. So we talked about the expectant management, medical and surgical, the different ones, and there's a combined or sequential management. Combined, an example of the combined is uterine artery embolization and methotrexate. So you put the foam on the uterine arteries, embolize it, and then give methotrexate. The combination of both can give you a better effect. Or the sequential approach, like starting by methotrexate, and then after a certain time you can do another intervention, like surgical intervention, for example. So combined management is where more than one modality of treatment is used together or within a short interval, like the uterine artery embolization and methotrexate. This combined approach reduces the risk of bleeding, hysterectomy, and major surgery, and allows quicker recovery and discharge. Sequential management is where more than one method of treatment is used after a predefined interval. So I will start first by the medical management, okay? And if I'm not successful, or the fetal heart is stopped, within 2 weeks I will do surgery and remove the gestational sac. So this is sequential. As I said in the first slide about the management options, there is no consensus about it. But in general, the methotrexate is the mainstay of treatment. So how would you choose the treatment option? The treatment options should be individualized, taking patient-specific factors into consideration. Not only patient-specific factor, you can take the scar pregnancy factors itself as into consideration. You can use or can put into consideration your facilities at your hospital, whether you do interventional radiology or not, whether you have the surgical experience or not. Okay, but in general, the treatment option should be individualized. Expectant management is generally not recommended except in very rare situations, as we said, non-viable fetus with declining beta HCG, or a woman with the last hope for getting pregnant is this section scar. Medical management should be considered for hemodynamically stable women with minimal or no symptoms. Methotrexate is the drug of choice for medical management and works best in pregnancies of less than 8 weeks of gestation and where the HCG level is less than 5,000 international unit. Intralesional injection of methotrexate with sac aspiration has a higher success rate and should be considered as an option for stable women. Surgical treatment should be considered for women with significant symptoms or for those who decline medical management. For women with endogenous or endogenic scar pregnancy, surgical evacuation or hysteroscopic resection carries less risk of perforation, but the hysteroscopic resection should only be with experienced individuals, of course. Whereas surgical resection with resuturing should be considered for women with exogenic scar pregnancy and thin endometrium. So if you to choose between the evacuation, surgical evacuation, or suction evacuation, or laparotomy, choose the suction evacuation if the sac is growing inside the uterine cavity. If it is bulging outside, there's a risk of bleeding, even if you do evacuation from vaginally, like suction evacuation, in an exogenic type, the risk of bleeding is high. So you would be inclined, you would prefer to do laparotomy to control this bleeding if it happens. Transvaginal resection or laparoscopic resection should be considered over laparotomy where facilities and expertise are available. Different combinations of treatment should be considered in section scar of longer gestation and in those with failed or incomplete resolution of treatment. The follow-up time for beta HCG decline varies. So, and we have seen this with different patients. Some will respond very quickly and the beta HCG will decline rapidly. Others will take a long time. It depends on the gestational age at diagnosis, HCG levels at diagnosis, size of the sac at diagnosis, and the method of treatment. Women should be followed up till complete resolution of beta HCG and the cesarean section mass. So you will start the treatment, as we said, like a tubal ectopic pregnancy. You will start by doing the beta HCG today and give methotrexate, then day 4 and then day 7. And you see the decline of beta HCG. And if the beta HCG is declining, you do scan. If the scan is the fetus is non-viable, then you can follow up on a weekly basis until the beta HCG is 0. And don't expect significant bleeding unless the beta HCG is almost nil, 0. So if you start a beta HCG with 5,000, for example, and you give methotrexate, the baby dies, beta HCG is 2,000, you would not expect the patient to expel the pregnancy at this stage. It's only when the beta HCG is very low, you are talking about tens, 20, 30, 40, 50, or even below that, when the patient starts to have significant bleeding and expel the sac herself. So long as the beta HCG is high, you would not expect the spontaneous expulsion. In most cases, I would say. Following initial dose of methotrexate, beta HCG levels may initially rise, the same as in ectopic pregnancy, and the size of the mass may increase due to trophoblastic necrosis and hemorrhage around the sac. Again, exactly the same as in ectopic pregnancy. Conservative management is associated with longer treatment time compared to surgical option. Counseling is very important to counsel about the duration of treatment, the possible complications, the interventions that you can do. Everything should be clear to these patients. Those patients are, from what I have seen, exactly the infertility patients. They are very well educated. They are very anxious about the treatment options, and they will nag you all the time about why I'm not bleeding yet, why it is still there, why I'm not miscarrying. So it is very important from the start to tell the patient, for those going for medical management, that the medical management will take long time. Give them the 3 months as a rough estimate. It will take up to 3 months for the treatment to be completed. So don't rush things. Wait until things go good for you. Immediate access for any emergency. This is very important. If you are treating a patient with scar pregnancy, you are not going to admit the patient the whole time in hospital. Okay, so beta HCG is declining. Okay, then they will discharge the patient and bring her every week or every 2 weeks, whatever. But there should be the facilities for emergency treatment should be available. Your phone number should be with the patient. If anything happens, should contact you. I do this with my patients. If any problem happened, if any significant bleeding, call me and go straight to the hospital. The hospital and hospital staff in general should be familiar with the treatment of this patient. Okay, so the patient, if she comes to them in an emergency, they know what they are facing and they know what to do with her. What about the pregnancy following the treated scar pregnancy? Scars arising following cesarean and scar pregnancy may heal by fibrosis. So the healing will be by fibrosis. Okay, if there is a persistent defect with a thin myometrium over the scar, resuturing of the defect can be considered prior to next pregnancy. And this is what the doctor was asking me. Resuturing can be done vaginally again, by dissecting the vaginal wall from the cervix and moving out, dissecting the bladder and getting to the scar niche and resuturing it. Many reports of successful pregnancies following medical or surgical treatment has been published. Early ultrasound scan, of course, this is very important. If a patient has a scar pregnancy before, do an early scan for her to diagnose it as early as possible if it is going to be recurrent. In all reports, the following pregnancy terminated by cesarean section: query beneficial and proper closure of the lower uterine segment. So yes, it's very important to, when you do cesarean section, to properly close the lower uterine segment for not to have a recurrence of the scar pregnancy. So in conclusion, rising C-section rates increase the incidence of scar pregnancy. Prompt diagnosis of the condition is required to reduce associated morbidity. High index of suspicion, you have to think about it all the time, is required for women with suggested history of scar pregnancy. Ultrasound scan is the diagnostic tool of choice. Management options include medical, surgical, and interventional radiology, and appropriate patient selection is important. Major hemorrhage and hysterectomy are the main risks associated with scar pregnancy. Adequate counseling and availability of surgical expertise and blood transfusion should be part of a comprehensive management strategy. And thank you very much all for your listening. I'm sorry it took too long.
Thank you, doctor. Thank you.
Thank you.
I
Thank you.
always-
Thank you, doctor. Thank you.